Our next speaker led the implementation of many of the provisions of the ACA that Jenny mentioned that impact children's health through her previous role as Deputy Administrator and Director of the Center for Medicaid and CHIP Services at CMS. And we're so honored to have Cindy Mann with us today to share her perspective on the policy issues impacting children's access to coverage and care.
Thank you. It's a pleasure to be here. I want to thank NIHCM for organizing this webinar. It is really so important to keep a focus on children as we continue to move forward on improvements in coverage and care. I also want to offer a note of appreciation to Jenny Kenny. She has really been our guru, and when I say our, I really mean everybody who cares about kids' coverage, in terms of tracking and explaining the data and giving us all really a wonderfully granular insight over the years into how well we are doing and where our challenges lie. So we all owe a lot of gratitude to Jenny and to her colleagues at Urban. I'm going to talk briefly this afternoon or this morning, depending on where you are, on specifically about enrollment and retention issues and a little bit about access within the framework of the Medicaid and CHIP programs, and really with an aim towards focusing on continued improvements and ways in which we can keep the trends strong and moving in the right direction, given the place of strength that we're in now with respect to kids coverage, but also where we still have issues and challenges and improvements to be made. So, but I have to begin, I think, with a celebration and just reminding everyone who's listening today about the gains that have been made, which of course Jenny's slides cover as well. But it really shows, I think, through very concerted efforts that have been made at the community level, at the state level, and at the federal level, that we really can make not just a dent, but really a remarkable improvements in terms of children's coverage. And we've seen the insurance rate for children been cut by nearly in half since 1997, and as Jenny talked about, potentially we're going to see the rates continue to drop, which of course is everybody's goal, to get to near universal coverage for all children as a way of making sure that they get the care and the financial security that they need to be able to be well and to thrive. This next slide just gives us a sense of where the ACA brought us in terms of some of the enrollment and eligibility issues that Jenny referenced. As I think we all know, the Affordable Care Act, the ACA, brought in a new vision around eligibility and enrollment, and it was really triggered extraordinary changes in how the Medicaid program operates in terms of enrollment and eligibility for adults. And this is without regard to which state has expanded coverage for adults and which state it hasn't. But the changes also were very significant for kids. Many of the changes that happened in the ACA were some best practices that some states had adopted previously for children. But having them become the law of the land has really moved it to a new plane. So I'm going to go through the next two slides are really broken up to understand what the new vision is in terms of some of the specific components that have changed the landscape on eligibility and enrollment, both in terms of requirements that all states need to adopt. And then the second slide that I'm going to cover in this series is about some options that states can adopt. And there are, I've selected some, there are actually many others that states are looking at and are contemplating all the time. So looking at this slide, which I've called Getting It Right, best practices are now the law, the reason I want to emphasize this is because I think for so many years we've been looking at each other's work across the states, in communities, and thinking about what are the best practices. And in many ways, the Affordable Care Act picked up many of these best practices that were going on for kids, and made them a requirement. And in order for states to implement some of these changes, if not all of these changes, they really had to undergo some very significant revisions in their information technology systems and their eligibility enrollment policies, as well as their IT infrastructure. And so while this is the law of the land, and I'm going to go through some of the elements here, it isn't always fully in place in an optimal way in every single state. And so it's important to keep track of these and not say check the box, it's the law, it's all done, but to make sure that in each and every state we're continuing to refine the implementation of these elements so that they are functioning as efficiently and effectively as they are intended to do. I mean, fundamentally, of course, the Affordable Care Act really changed the paradigm and created the expectation that if you are eligible for coverage, you will be enrolled and retained in coverage for as long as possible, for as long as you remain eligible. And then if you're not eligible for coverage in one program, you would you have a responsibility, and the system itself also has a shared responsibility to help facilitate the transfer into the appropriate mechanism for coverage if your circumstances have changed. So we start off with the concept that there are many doors to get into coverage, but there are no wrong doors onto the ACA vision. And to facilitate that, what the ACA required every state to do, and this is for adults as well as for children, non-elderly, non-disabled adults, and there's some requirements also kicking in for the elderly and disabled individuals, but I'm going to focus these comments really on non-disabled, non-elderly adults and children, is to have one coordinated, simplified application across all of the programs, Medicaid, CHIP, the marketplace, and for states that run a basic health plan, which is an option for states, also the basic health plan. And the idea is that people don't know which program they may be eligible for. People may be in a family may be eligible for different programs, and so you have one application process. You go through that process, and at the end of that process, each member of the family that may be applying is enrolled, hopefully many of them in real time, to the appropriate program. And so you start off with that single streamlined application, and you may have a parent who's eligible for a marketplace enrollment and a marketplace subsidy and cost-sharing reduction. You may have a child who's eligible for Medicaid or for CHIP, but that single application process and that, hopefully in many cases, that single sitting in front of the computer, either with a navigator or a community assister or late at night alone in the family living room, will accomplish that enrollment. And that's obviously a very big change. Some states had combined applications for Medicaid and CHIP, but the connections weren't always as smooth, and certainly linking to the marketplace vastly simplifies the process for individuals and for families. So while the requirement is in place and while nearly every state has this in operation, there are still improvements that can be accomplished. And so it's not one of those check-the-box kinds of things. It's something that you always want to be looking to make sure that the actual implementation is working as intended, that the application, the wording on the application, different ways the application is structured, is designed to be as efficient and effective in getting people through the process and enrolled in the appropriate program as possible. So that's really so central to the new eligibility enrollment system, but I want to note a couple of other things that are also very critical. One is the Affordable Care Act created a hospital presumptive eligibility. There was always presumptive eligibility for children and pregnant women. That's an option for states, but all states are to implement a hospital-based presumptive eligibility so that if you go to a hospital, and they're a participating provider, they can preliminarily enroll you into coverage, adults and children, and make sure that there's no delay in coverage as you finalize the enrollment process. A very key improvement in the process is that third bullet, which is reliance on electronic sources of verification. Years and years ago, families had to go in and apply in person, and they had to bring a multitude of documents to establish their eligibility. We now live in a world where many of those factors of eligibility can be verified through real time through computer, through electronic mechanisms. And so that has vastly simplified the eligibility and enrollment process as well as improved, I think, program integrity. We have also a number of features in the Affordable Care Act that focus not just on the initial eligibility and enrollment, but also on renewals, because we've known through all our work on kids coverage that it's often the case that a child may be enrolled in the program but then lose coverage at the point of a renewal or redetermination. And so the electronic sources of verification are required to be relied on both at eligibility and at renewal. And the other thing that the Affordable Care Act does is say that there'll be 12-month renewal cycles, not more frequent than 12 months unless there's been a change in circumstance. And that was a big change for a number of states. The other thing about renewals is the next box, or the next bullet, which shows that the renewal process is supposed to first look at what's available electronically and then only knock on the door of the individual or the family if there's something missing, meaning that if a state is able to renew based on information already available to it, wage data sources, SNAP data, other kinds of information, that it can simply go ahead and renew the individual and send them a notice of renewed coverage. If they do that search for electronic data and something's missing, then they reach out to the family and ask for the missing information. So a streamlined renewal process based on available data. There's also a provision that if somebody misses their renewal date but comes in within 90 days, that they can be re-enrolled into the program without going through a whole new application. And I also wanted to mention sort of a substantive coverage change for children, which is a requirement that all states provide coverage to former foster care children up to age 26. So that's an important feature to keep kids coverage, and particularly vulnerable group of kids coverage as they age. The next slide talks or identifies some of the measures that states can do to even further enhance the ability to reach all of those eligible children and to keep them covered for as long as they're covered. I'm not going to go through all of these. You can look at them on the slide. But one of the ones that have been very useful to a number of states as they've been doing both enrollment and renewals is to use data from other programs, and particularly to use the data available from SNAP to be able to just automatically enroll individuals, and CMS has issued some new guidance around how to use those data to be able to renew people as well. And I also want to specifically call out an option that has been in place for a while, which has proven to be very helpful for maintenance of coverage for children, which is 12 months continuous eligibility. It's available as an option for states both in the Medicaid program and in the CHIP program. And then this next slide shows you which states have taken up that option. We have some states that have done it for Medicaid only, some states that have done it for CHIP, and some states that have done it for both programs. So it's another area to be looking at in terms of further improvements, as well as a reduction of administrative burden for state agencies, and in some respects also for managed care plans to keep that continuous coverage going in states that rely on managed care organizations to provide the services to children. This next slide just gives you a little bit of sense of what one state has been able to accomplish through a variety of these mechanisms. And over a period of years, Louisiana has been one of the leading states in enrollment and retention of children. And you'll see that it has reached a point where 95% of the kids overall are renewed through many of these mechanisms. And in many instances, they're renewed 90% of the cases in Medicaid, 84% of the cases in CHIP. They're renewed without the families providing any additional information. They're renewed because they are able, the Louisiana Medicaid and CHIP agencies are able to rely on information otherwise available. So they have less than a 1% loss of coverage for procedural reasons, meaning the kids, we lose kids in coverage not necessarily because they're not eligible, but we tend to lose them for these procedural barriers. And Louisiana, through a combination of the kinds of things that are outlined in the prior two slides, have really been able to, reduce those procedural closings to almost none. And I would add, has done so with very strong results in terms of limited errors. So it's maintained program integrity. In fact, it's increased program integrity as a result of its reliance on some of the electronic data sources. So lots that can be accomplished here. I do want to touch on, as promised, an issue around access. As Jenny's slide showed, Medicaid actually and CHIP do well overall in terms of providing access to care for children, and that's always something that we need to focus on and keep paying attention to, because at the end of the day, that's really the purpose of having coverage, is to make sure people can use that card and get to the care and get quality services that they need. But we always want to do better, and there are areas of access concerns that arise in different parts of the country and for different kinds of services. So just 2 points I've pulled out here to help us think about areas of improvement for access. One is some analysis that was done, and this is a CDC survey looking at children's use of emergency room. And one of the things noted in the CDC analysis is that so many of the children who went to the emergency room with Medicaid coverage for non-serious medical problems, meaning it wasn't necessarily a visit that required a visit to the emergency room, were going to the emergency room after hours when their doctor's office was not open. And thinking about how families can access care when often they are not in a position to take time off from work and to go to a doctor's office or clinic office during their work hours, and how we can make sure that we have systems of care that really meet the needs of the families who are served by the Medicaid and CHIP programs. Lots of, I think, new developments along this area, but more improvements, I think, still need to be made. And it's always important to focus on dental care, because we've really had a long-standing problem in the Medicaid and CHIP programs, Medicaid in particular, but really both programs in terms of accessing dental care, although as Jenny's data show, looks like there's some recent improvement in that, which is very much welcome and a product of a lot of effort in this area. So I'm highlighting here also not just the data, but that CMS has been working with states and providers on a concentrated effort to improve oral health care for children, and there's a link here in the slides for some additional information on what's available, best practices, and so forth. And finally, I'm going to close with a note on the importance for children of their parents being covered. And I think there's been lots of data over the years suggesting the relationship between the value of having parents covered and having their children covered, and their children accessing care. And there's also data on how the health, in fact, of a parent, and probably we don't all need data to show us that, it's logical, but when a parent is healthy, it's likely that that will benefit their children. There's been a recent analysis and focus on that, particularly for parents with mental illness and the benefits that coverage and care for the parents can provide to the children. So this map shows you which states have taken the steps to expand Medicaid coverage for parents. We now have 31 states, or 30 states plus the District of Columbia, that have taken up the ACA expansion in one form or another. And we have 20 states that remain in the category of not having yet expanded coverage. Very important area, obviously, for the parents, very important area for the healthcare system generally, but also from the perspective of kids. And I think I'll close with that.